Thank you very much for inviting me. So my slides will be in French, but the discussion will be in English. And that's really what I've tried to do is really come up with some clinical examples. So just a few declarations. I was part of an advisory board for Ultragenics and Novartis in the context of rickets and spinal muscular atrophy. And I'm a co-investigator for an RCT that's looking into a new medication for osteoporosis with funds going to my institution. But neither of these has an impact on the content of this presentation. So the objectives that were kind of given to me were, how do we recognize some clinical elements and some initial radiological features of metabolic bone disease in children? What are the first initial tests to prescribe, and what are some of the ways to treat, especially in primary care? And when is it time to refer to a specialized clinic? So just really a quick recap. As I'm sure you all know, bone is really a composite material. So you have an organic portion, which is the collagen. So it's really that protein. And then you have the calcium and phosphate, which crystallizes, also called hydroxyapatite, which then lays over the protein. And it's that gives the strength of bone. And that's really important when you're in front of a patient and in front of an X-ray. The first thing to ask yourself is this a collagen problem, or is this a mineral problem? Okay, so let's start with some problems with mineralization. So like I said, we'll be doing this through some case studies. So you see Leo in your walk-in clinic, and his mother brought him because she finds that his wrists seem a bit swollen. He seems to have some pain in his lower extremities, and although he was progressing and developing well up until a few months ago, he's refusing to walk, and although he's used to crawl on all fours, now seems to be hesitant to do so. On clinical history, you find that he was exclusively breastfed till about 8 months of age, had no vitamin D supplementation. So his diversification of diet was a little bit late. And when you put him on his growth chart, you see a really slowing of his stature. And this is what you see on your physical exam. So this is clearly the classical signs of rickets. You see bowing here in the femurs, a genu varum, and even a bit of bowing here in the tibia. And the swelling of the wrist actually has nothing to do with the wrist joint, but actually the metaphysis of the bone, which is the proximal part here, just proximal to the joint line. And then the same thing, because you have an enlarged metaphysis here of the radius and ulna, you also have enlarged metaphyses of the ribs, and that's what gives you the classic rachitic rosary. So you want to see what's going on. So the first thing to do is you order an X-ray, and you want to order that wrist X-ray. And just off the bat, you realize that something's off. You can see here the growth plate looks very, very strange. And when you compare it to a regular hand of an 18-month-old boy, you can see, first of all, that the bones are definitely different in transparency. So Leo is very, very under-mineralized. Here you have, in the normal wrist, you have this nice, clean, crisp line, thin bones, whereas here you have a widened, cupped, and frayed line. So these are the classical signs of rickets. If we look closer here, we can see it. So again, the cupping, the fraying, and the splaying. So these are the signs that you'll find on X-ray, and these are the findings that the radiologist will report. You may also find the bowing or the genu varum. If it was a chest X-ray, you'll find the rachitic rosary, and you can also have what's called as looser zones, which are kind of these pseudo fractures. But those can be rare. So why does that happen? Why do you see that on X-ray? Well, it's actually, if you take a growth plate right here, what happens is that you have all these chondrocytes, and the chondrocytes have to basically undergo apoptosis to then be calcified and become bone. And that's how you have lengthening and calcification of your physis or of your growth plate. But when you lack phosphate, or when you lack calcium, or both, or you're not absorbing it well, what happens is that those chondrocytes, they can't undergo apoptosis. So they swell up and they become completely disorganized. And that's why your growth plate also becomes disorganized. And so that's why you have that splaying, fraying, and cupping. So when you look at the hips of this patient also, so we can see at the knee, classic signs of rickets, but the hip, I mean, that is really, really severe rickets. So some people like tables, some people like classifications with diagrams. So let's start with the table. Rickets can be either hypocalcemic or hypophosphatemic. And what you'll find clinically is you'll still find some bowing and some deformations, pain. It is painful to have rickets. You'll have stunted growth. You'll have, even because you're lacking those minerals and you're in pain, that you'll have delays in development, mostly motor development. And if it's severe hypocalcemia, you can also have muscle spasms, tetany, or even some seizures. And in some of the congenital forms of rickets, you can really have a child who almost looks like there's a neuromuscular or neurologic disorder underneath. It can be quite hypotonic, but really it's rickets. So you've seen Leo, you've done the x-rays, you've done the blood work, you're leaning to one of the categories of rickets, probably nutritional vitamin D deficiency based on history and based on the fact that he had no vitamin D supplementation and the fact that he was exclusively breastfed. But when you consider it step by step, you see that rickets and osteomalacia can really be either because you lack the calcium or the phosphate, or you have it, but you're not absorbing it well, or because you're losing it or you're wasting it in some way, and that usually tends to happen at the kidneys, or because there's a local defect in bone. So if we go back to Leo, you've ordered the blood work. So what do you order when you've confirmed rickets on x-ray? You obviously calcium, phosphorus, magnesium, the parathyroid hormone, because that controls your calcium and your phosphorus, magnesium, because you need enough magnesium to be able to release the PTH into the bloodstream. You order alkaline phosphatase because it gives you an indication of bone turnover, and it will be high in rickets. And you want to look at what are his stores, what does his serum vitamin D look like? And that's 25 OHD. That is the level that's basically done in all labs across the country. And that gives you an idea really on what the stores of vitamin D are. I also always order a liver function test and kidney function test and a CBC. Why? Because I want to make sure I'm poking the child. So I want to make sure that his general health is good as well. And there's nothing underneath causing the rickets. For example, hepatic insufficiency or a kidney problem that's going unnoticed. So that's what I've ordered in Leo, and these are his results. So as expected, my alkaline phosphatase is high. That's what you're going to have in rickets. As expected, my PTH is high because this is likely a vitamin D deficiency. And in fact, you've confirmed it. Vitamin D is very low. And here, however, you also have a kind of a mild but still significant hypocalcemia, despite the fact that the PTH is high. So here we're really into, with the blood test, you've just confirmed that we're really into a lack of calcium and a lack of vitamin D, probably coming from the diet. If your liver function tests are normal and your kidney tests are normal, it's unlikely to be pathologies originating from there. This is interesting to me because this helps us understand why some kids develop rickets and some don't, even though they may have some insufficiencies or deficiencies in their diet. Your skeleton is an organ. It is not a static organ. It's a very dynamic organ. And in fact, it can actually really compensate. So if you have just mild insufficiency in vitamin D and calcium, or if you're only deficient in one of the two, you may find some early biochemical changes in your blood work, like an elevated alk-phos, a slightly elevated PTH, but your phosphate and your calcium will tend to be normal, and your child actually may be very asymptomatic, and your x-ray may actually look normal. However, if you start to get severe deficiencies in both, or an insufficiency, for example, in calcium and a deficiency in vitamin D, then the skeleton is no longer able to compensate. So not only will your blood work show signs of rickets, but your x-ray will confirm your rickets as well. So there's been a lot of confusion about what is deficiency, what is insufficiency, what's toxic, what's optimal. So this is what we have agreed upon on pediatrics. And this is really from a bone health perspective. There's lots of studies going on and looking at doses of vitamin D for other things like asthma and inflammatory bowel disease, but really for bone health and just for general health, the common consensus is you're deficient when it's less than 30. When it's less than 30, we know that the skeleton is going to be somehow affected. You're insufficient when you're 30 to 50, but it's possible that you have actually no signs. And if you have enough calcium in your diet, that can be completely well tolerated. So ideally, we consider you sufficient when you're above 50, and ideally, we want to keep you between 75 and 125. And toxicity really happens above the 200, 225 nanomoles per liter. So we really have quite a comfortable space. So if you have a child coming in with 12, like Leo did, nanomoles per liter, you can give him a big bolus of 100,000 units in one shot, and it's almost impossible to get to a toxic level. And if it is, it's very transient, and then it will come down really quickly. Why I stopped this at 125, just because for some kids, for example, with leukemia or with other forms of cancer, the guidelines suggest not, to keep them in the optimal level and not to get vitamin D too high in the serum levels. So what about calcium? So I've given you a table based on age. Just to give you an idea what 700 milligrams of calcium is in terms of dietary. So 1 cup of milk is about 200, 250 milligrams of calcium, and that's one portion. One little piece of cheese is about the same thing. So like a Petit Québec or a Ficello, and usually one little tub of yogurt is about 250. So if you're having 1 cup of milk, 1 piece of cheese, and a yogurt, you're definitely getting your 700, and you're probably close to your 1,000 as well. Phosphorus, we get in our diets. It's almost impossible to be phosphate deficient in our diet if we're healthy and we have healthy kidneys, because phosphorus is in everything. Phosphates are used as food preservatives. And so in that North American diet, it's everywhere. So it's really calcium that you have to pay attention to. And I just want to show you how important it is in that pubertal period to really up that calcium intake even more than an adult who's finished their growth. So now, practically, when you want to prescribe some calcium supplements, what do you prescribe? What's out there? You have a choice. You can prescribe in elementary calcium and realize that elementary calcium depends on the type of calcium that you're prescribing, and that not all calciums are absorbed equally. What I tend to do, especially for younger kids, is just go to something easy and cheap, and that's Tums. Tums or anything equivalent to that, Rolaids. So that's really just calcium carbonate, and they come in lots of flavors, and some of them even come in chewables. So I tend to prescribe either the Tums Extra or the Tums Ultra or an equivalent of that. And I tell them, for example, cut it in half to get 250 3 times a day or 500 twice a day. Basically, ideally you want to spread it out over the day to reach that 700 milligrams and 1,000 milligrams to favor absorption. But obviously being aware that the more times a day you have it, the chances are that the compliance will be a little bit altered. And also just to note that I always prescribe calcium carbonate or equivalent, because if you really just prescribe the Tums, or for example, you prescribe Truly Delights, they could be not covered by their insurance, or they could be quite expensive. The other option that you have are combinations. So I've given you one example, but there are more: Calcia, Caltrate, and others. They're all equivalent in my regard. So you can have basically with one pill, you got your calcium and you have your vitamin D, and you have different strengths here. And oftentimes when I know that I'm going to be prescribing this for a long time, like in rickets for 3 months, I tell the parent, go see your pharmacist and look at what the best options are for you. Because if the child is not taking it, then it's obviously not effective. Now, calcium can be a little bit difficult on the stomach and can cause constipation. It's rarely a problem in healthy kids that are just, have nutritional rickets. But if it is the case, you should know that there's calcium citrate. So it's absorbed a bit less, but it has less GI effects. And some of them, in fact, come in like a little powdered case that you could put with a liquid. And you also have already available liquid calcium. An example is salt Solucal, but there are others with or without vitamin D. Those tend to be expensive and need an exemption code here. So I tend to reserve those for example, kids with CP or kids with jejunostomies or gastrostomies who've had their calcium block their tubes or things like that when you really want to get something liquid. The flavor they have different flavors, so it tends to be palatable. So those are examples of things that you could prescribe. Now, a quick word on vitamin D. So vitamin D, unless we're going out in the summertime in Quebec and in Canada, it's very, very hard to get vitamin D in our North American diet. It's not impossible, but that's why, in fact, all milk practically across North America, definitely across Canada, are all supplemented in vitamin D. But just to give you an idea, you need approximately a liter of milk a day to get about your 400 units a day. So you don't necessarily want your toddlers drinking that much milk at that age. And here are some other options that you can give the parents, but obviously they tend to be less palatable for kids. So Leo, you've diagnosed him with nutritional rickets. Now what do you do? So based on his age and based on the global consensus recommendations, he's 17 months. So you're going to give him about 3,000 units of vitamin D per day for 3 months. That's your standard go-to treatment. You treat for 3 months. Now, because Leo had some hypocalcemia, even though it was mild, and even though he wasn't really symptomatic, he didn't have tetany or seizures or anything like that, I still want to make sure that he's taking his vitamin D and his calcium that I'm going to prescribe. So I'm likely going to see him again in the halfway points. I'll probably see him after a couple of weeks, after a month. That really depends on the clinical situation and the type of parent. Or you can also give one bolus dose, which can also be referred to as a STOS dose, and you have the doses here, which for his age would be about 150,000 units in one dose. So you do that for 3 months time, either that one single dose for one time or the daily dose for 3 months. And you're also going to give calcium to supplement that, because once the gut starts revving up the calcium absorption, you want to make sure that there's enough calcium in his diet so that he doesn't develop hungry bone syndrome. So you do that, and then 3 months later, you want to see him again, and you want to repeat the whole thing. You want to repeat the x-ray, and you want to repeat the blood work. And I'll tell you why in just a second. So that's what you've done with Leo. You've given him the 3,000 units per day. He's obviously taken it. These were his x-rays initially at the knee and the wrist. And these are the same patient, Leo, 3 months later after vitamin D. So you really see that difference. First of all, the bones appear denser. They're not perfectly dense, but they're much denser than they were. Even the shape of the bone looks different. And this is really the same patient that we had in clinic. And you see that the splaying has healed, the fraying and the cupping has healed, both at the wrist and the knee. Why do we do the wrist and the knee to look for rickets? Because those are the bones that are growing the quickest. And the bones that are growing the quickest, the ulna, the radius, the tibia, and the femur, well, those are the ones that are going to be the first to show rachitic changes. So that's why we go for those bones first. And in younger kids, I tend to do x-rays of both the wrist and the knee, just to make sure that, first of all, to make sure that I've seen the rickets, and just to make sure that both have healed, because sometimes you can actually have rickets just on the knee and not quite yet, subtle signs only on the wrist. So it's nice to have a picture of both. So you've repeated bloods, his calcium is completely corrected, his phosphate is normal, his alk phos is not completely normal, but definitely a lot better than it was. And that's what you want. After 3 months, you don't expect everything to be normal, but you definitely expect your calcium and your phosphate to be normal. The alk phos and the PTH, as long as they're decreasing steadily, that's what you want. And that's what you expect to see if this is nutritional rickets. Now, if that doesn't happen, so you've done everything, you've done the blood work, you've repeated the x-rays, you've made sure that the child has actually taken the supplementation and nothing's getting better, well, that's the time where you start referring to a specialized clinic, to endocrinology, or to whoever the bone specialist is in your clinic or institution. Or if you have refractory hypocalcemia or refractory hypophosphatemia, despite giving adequate supplementation, it's time to refer. So in your patients, who should you think of? Who is at risk for having insufficient calcium intake in the diet? Well, definitely vegan diets, people who have allergies to dairy products, those who have obviously very low intake of dairy, a very high protein diet, because that increases the excretion of calcium via the kidneys, children with lots of malabsorption, ketogenic diets for kids on epilepsy, kids who have long-term corticosteroids, or other types of medications like antiepileptics, for example, that will interfere with the way calcium and vitamin D are metabolized and absorbed. Who's at risk for vitamin D insufficiency? So obviously premature babies, children who are born with moms who are very deficient themselves, because the first 2 to 3 months of your vitamin D intake, if you're not taking supplementation, actually comes from the mom. So the child is born with about 70% of the vitamin D stores that the mom has. So if she's already deficient, then the child already starts off further behind. Obviously, kids who are exclusively breastfed and don't have supplementation. Anybody who has a kidney disease or a liver disease. Why? Because we need those two organs to function, to hydroxylate the vitamin D, and therefore to activate and make it useful and usable by the end organs. Kids, like I said, who are on antiepileptics, kids who are on antiretrovirals, steroids, and even ketoconazole, malabsorption, obesity. Why obesity? Because the vitamin D gets trapped in the fat cells and doesn't really become metabolically active. And obviously, as you know, people who, recent immigrants who have migrated from, a low latitude country to one like ours with a lot less vitamin D exposure, sun exposure. So this is a really quick word for rickets and fractures. So like I said, so rickets and osteomalacia, basically the problem is you're lacking calcium and phosphate. So you're lacking that mineralization, but the bone, the protein of the bone itself is normal. The collagen underneath should be normal. So your bones are actually not wanting to break, but they're really bending. Osteomalacia is what we see in the diaphysis, so in the body of the bone, and the rickets is really what we see at the growth plate. That's why adults can't have rickets, because they don't have growth plates. But both kids and adults can have osteomalacia. So that's why your bone is unlikely to break unless you have these fractures that are kind of insufficiency fractures. So you have a child who has a really bad rickety wrist and is constantly crawling on all fours. You might have a little bit of a fracture on presentation. Or if you have, for example, a child who's still, who's starting to walk, starting to weight bear, has been rachitic and now has an insufficiency fracture. But it still remains rare, and it really is only seen when the rickets is severe on X-ray. That's a really important element to keep in mind. And also a quick word about vitamin D. If you have a child who is only vitamin D deficient or insufficient, if he does not sustain a trauma, a spontaneous fracture will not occur. So there are lots of studies linking low vitamin D to more fractures, but these studies are all epidemiological, and there's lots of confounding effects. And so really there's no robust evidence that shows that a low vitamin D alone, without any signs of radiological rickets or osteopenia, does not increase a child's fracture risk. Now, if that child has trauma, and he's more likely to fracture from that trauma, if that trauma is appropriate for that type of fracture. Okay, so another case of rickets. This time it's a boy who's 12 months old. He's Caucasian. He has a diversified diet. He was taking vitamin D supplementation until about 9 months of age, and then kind of the prescription ran out and it wasn't taken again. The child has genu varum. He also has kind of a global developmental delay. He's hypotonic, and the mom reports what you think is some muscular twitching. You do the x-rays and you see the rickets. It's confirmed. So you do his blood work. Now here you have the alk phos that's increased, you have the PTH that's increased, and you're lucky to get a really quick vitamin D level, which is sufficient. Your phosphate is normal, but your calcium is really, really low. This is severely low calcium. You can see that calcium, the interval is quite narrow. There's not a lot of play for serum calcium, and that's because almost every single cell needs calcium to depolarize. So when you have such a low calcium, you can understand why the child is hypotonic, has a global delay, is not growing, and has some muscle twitching. So when you see a very low calcium, and when you hear in the history that it's unlikely to be vitamin D deficiency because he was supplemented up until a couple of months ago, and when you have muscle twitching, I strongly recommend, since you're poking the child, get also the 125 vitamin D level. And the reason for that is because you want to figure out, is this really nutritional rickets or is this something else? And in this case, it's likely to be 1-alpha hydroxylase deficiency. And when you get your 125 level, you actually confirm it. So despite having a hypocalcemia, your 125 is really low and it's abnormally low. So what does that mean? So when you're in a state of hypocalcemia, really your PTH gets revved up. Why? Because the calcium sensing receptor in your parathyroid hormone senses that low calcium and will release the PTH into the bloodstream. The PTH will act on bone, will act on the kidney, and will act on the intestine. On bone, it'll rev up the osteoclasts to start resorbing bone. So you have a really quick release of calcium and phosphate into the bloodstream. On the kidney, it'll rev up 1-alpha hydroxylase to be able to turn that 25 vitamin D, which kind of sits there as a storage vitamin D, into the active form of vitamin D, that 125. So the PTH will rev up 1-alpha. So you have more hormone vitamin D, 125, and this acts on the kidney by increased calcium reabsorption at the expense of phosphate. So you're going to lose phosphate in the kidney, in the urine, but you're still going to reabsorb lots of calcium. That 125 vitamin D, though, also acts on the intestine to a lesser extent and a slower extent, but it will act on the intestine, and that'll increase also calcium that's reabsorbed by the gut and phosphate that's reabsorbed by the gut. So the net effect of that PTH activation is increased calcium, if things work well, and a net decrease in phosphate. So despite the fact that you're increasing phosphate in your intestine, you're still losing quite a bit of phosphate in your urine. And that's a normal response to hypocalcemia. So when you have a deficiency in that 1-alpha hydroxylase, basically you're losing the ability to activate your vitamin D into the active hormonal form. And so this is known as a hypocalcemic congenital rickets. It's an autosomal recessive disease where you have a mutation in the CYP27B1, which encodes that enzyme. The symptoms happen in the first year of life. The child is really, some of the kids that we have in our clinic almost went to a muscular biopsy because they thought that the child had a neuromuscular disorder, but really it was 1-alpha hydroxylase. So side note, if you have a very hypotonic child, calcium should always be part of your initial screen. So this child also, so hypotonic, delay, you can also have hypoplasia in the enamel of your teeth, tetany, seizures. You may find a little bit of hypophosphatemia because your PTH is really high, but really what predominates here is the lack of calcium or the hypocalcemia. And these kids should definitely be referred to a specialty clinic. And we're going to treat them with the active form of vitamin D, which is calcitriol or rocaltrol. Now, really quick word, because this is really, really rare. You can also have resistance to vitamin D. This is where your 125 is present. It's just not effective because the receptors of vitamin D in your end organs are not accepting it, are not being able to use that 125. So the rickets happens in the first 2 years of life, and some kids actually have alopecia or ectodermic dysplasia because of the lack of because of the mutated vitamin D receptors in the keratinocytes. How do we treat these kids? It can be quite difficult. They really need high doses of calcitriol, high doses of calcium, and sometimes even intravenous calcium. Okay, case number 3. Also about 12, 13 months, growth delay, bowing. The other thing that this child has, though, that the others didn't, is he has some swelling in his teeth, which you feel like maybe dental abscesses. He doesn't have fever, doesn't seem really hot or infected, but there's definitely swelling that you see in the gums. You do his, so he definitely has rickets on x-ray, you do the blood work, and what predominates here is the low phosphate. But your PTH is increased, so you wonder, oh, is that just because, you know, that's the effect of my PTH trying to keep my calcium normal, or is it because there's something going on with my phosphate? You're waiting for your 25 OHD, and you've also happened to do a 125 as well, and you get those results. So you see that the 25 OHD is actually almost sufficient, almost normal, and your 125 is just shy of abnormal, but that's not appropriate in the setting of hypophosphatemia, right? When you have low calcium, when you have low phosphate, you would want that 125 to be high, and it's not here. So what type of rickets is this? It's probably hypophosphatemic rickets. So in this case, why does that happen? Because you have a mutation that affects the hormone that's called FGF23. All you need to know is that your bones are also an endocrine system, so they actually secrete the hormone that goes FGF23, which will act on the kidney, and that basically is a phosphate wasting hormone. And why was your 125 low? Because FGF23 also suppresses your 125. So it's just really, it's a rare disease in about 1 in 20,000 kids, but it's still really important. I really wanted to mention it today because the earlier you treat these kids, the better their height potential is, the less likely they are to have permanent malformations. And also these kids tend to have some of the phenotypes also include dental abscesses, and that could be really traumatic for a child to have, you know, extraction of teeth really early on. Some of them can actually also present with craniosynostosis. These kids tend to be achy because they have enteropathy. They tend to be a little bit more fatigued. And like just this chronic pain. So the earlier we see them, the earlier we get them treated. So that was a lot, and I'm sure it may have been difficult to retain everything, but I've done a table to kind of just summarize the different forms that I think are important for first line and secondary care providers. So when it's a problem with calcium and or vitamin D, really what you're going to see is low or normal calcium, but low vitamin D. When it's a problem with the enzyme, the 1-alpha hydroxylase, apologies, what you're really going to find is the low calcium and that low 125. When it's a resistance, that 125 will be really high, despite your calcium being, but your calcium doesn't respond, so it'll be low. And in hypophosphatemic rickets, really the thing to look for is the phosphate. Okay, so we're going to go to Matteo. Matteo has autism. He's always had a very restrictive diet, and he's come to your clinic with swelling in his lower extremities. He's not walking over the last couple of weeks. He's even started to have a little bit of gum bleeding when mom tries to brush his teeth. And the only thing that's really changed in the last month is that for some reason he's stopped drinking his juice. But he's had a very restrictive diet. This is an actual patient of mine who only ate ramen noodles. Sometimes he had a little bit of vache qui rit inside, and sometimes he had a little bit of tuna, and he had 1 juice a day. And for the last month and a half, he's just stopped wanting the juice. So what is this? This is actually scurvy. So deficiency in vitamin C, because vitamin C is really important for osteoclast and osteoblast activity. So really, whenever, I think the take-home message here is scurvy also can present as a metabolic bone disease. It's very painful. They can stop functioning, and not just the bleeding gums or the hemolytic anemia, but you can also really have bone pain. And there's classic radiological signs, which I'll skip for now, but the radiologist should be able to see them. But these kids, when they have it, like, they're so non-functional. And if we don't think about it early, this child was hospitalized because he just was not walking. This was a child who would get up and dance on the table every day because he loved music, and he had stopped walking and stopped getting out of bed. And at first, the radiologist thought that he had leukemia because the bone marrow was swollen and the metaphyses were really, really active. But only the metaphyses were active, not the entire diaphysis of the bone, not all of the bone marrow. So that's what led us to think it was scurvy. And so although it takes a long time to actually get your vitamin C level from a lab, if you think it's scurvy, just treat it. Because if it is scurvy, the treatment will give you the diagnosis. So we gave high doses of vitamin D, and it's easy because you can give it by mouth, intramuscularly, or IV for 7 days straight. And by day 3, you should already have an almost resolution of the bone pain. It's that quick. The anemia and the hematological disturbances, that takes a little bit longer, but really the bone pain will really quick. So within 3 days, this child who had not walked in a month was back on the table dancing. So even though I didn't have my vitamin C level, it was clear that it was vitamin C. So take home message: for kids who have very restrictive diets, or in the context of autism or other pathologies, I highly suggest a multivitamin, because all you need is about 10 to 25 milligrams of vitamin C a day, which is kind of like the equivalent of a juice box or 1 fruit a day. That's all you really need. And as soon as you don't have that in your diet, you can get scurvy really quickly. So that was my take-home message. So I know that the time is going quickly, and I have a bit, maybe 10 minutes left. Is that okay, Sarah? Yeah. So let's just quickly talk about bone fragility or osteoporosis. So why is this important? It's important because sometimes you're going to order a bone density scan if you're following a child, or your child may have had a bone density scan ordered by a specialist, and then you get the report, and the report says low bone density, or you get an x-ray and it says osteopenia. What does that mean? Does that mean that we have to start medications? Does the child have osteoporosis? No, the answer is no, because osteoporosis, unlike in adults, is not diagnosed based on DEXA or bone densitometry alone. You really need significant fractures. And a significant fracture is either 2 long bone fractures before 10 years old, or 3 long bone fractures before 19 years old, and a low bone density score. So if you have that combination, it's possible that you have osteoporosis. If you have vertebral fractures, vertebral compression fractures, and you were not in a high trauma accident, and you don't have a local lesion really cracking down on that bone, then there is no reason that a child should have a vertebral fracture unless he's been in a car accident, or unless he has like a tumor in that vertebra. That's really, really important. And whatever the bone density is, that child has osteoporosis. Okay, so vertebral fractures in children in the absence of high energy trauma is always pathological. So we can order a bone density when we suspect bone fragility, sure. We don't look at the T-score, we look at the Z-score, because the Z-score is age and gender matched. T-scores are really only for older adults. And why is that distinction between osteopenia? So osteopenia really just means low bone density, that's all it means. Osteoporosis means that there are significant fractures. And why is that important? Because we will only treat children for osteoporosis if they have osteoporosis. There's no indication to treat them for osteopenia alone. So when you find osteoporosis, your first question is, well, is this congenital, or is this secondary to something that I'm maybe missing here? So obviously when it's congenital, like osteogenesis imperfecta, there are some clinical or physical signs. So let's take this case of a boy who's 3 weeks old. He's from Manawan, Atikamekw region. Bowing in the femurs was actually seen antenatally. So obviously this is pathological. He had his workup done, and this child does have osteogenesis imperfecta, the specific mutation that is common in the Atikamekw population. And just to show you how fragile bones can be when you have osteogenesis imperfecta prenatally, he was hospitalized for in an accidental fracture because he fell out of mom's arms, and he fractured his humerus. So he was hospitalized, and during hospitalization in a specialized hospital, knowing that he had osteogenesis imperfecta, he managed to fracture his other femur with very, very gentle handling. So this is how fragile these bones can be. And it's also really important to distinguish between pathologies that are characterized by bone fragility versus those that are associated with bone fragilities. There's too many to mention, and it's beyond the scope of this talk, but really the ones that are characterized are osteogenesis imperfecta and hypophosphatasia, but we'll only concentrate on OI for now. So I'm sure you've seen this before: small stature, could be macrocephaly, triangular facies, easy bruising, lots of flexibility, pectus excavatum, and obviously fractures in some who have blue sclera and dentinogenesis imperfecta. But the phenotype for OI is very, very different. But the take-home message here is, if you have a baby who's non-mobile and who's fractured, this baby and has OI, that is a severe phenotype, right? So severe phenotypes almost always have antenatal signs on ultrasound, on prenatal ultrasound, or they have neonatal fractures if there was no workup done prior to birth. Whereas the other phenotypes may only start to fracture after the child starts to become weight bearing. So if your child has had normal ultrasound, is growing well, and all of a sudden is not mobile and has a fracture, it's very unlikely to be OI. So the other types start to happen in the older ages, again, when there is more demand placed on the bones. And the genotype also varies across the phenotype. So it's not just always all the same type of mutation. So when you suspect OI, that's why it's important to get a referral to either bone mineral clinic or genetics. I think we'll pass that. And we have lots of different features. You can have Wormian bones. This was our child who was born with this bowing of the femur, and that's because he was just constantly fracturing while he was in utero. And then he had a diaphyseal fracture of his radius. And so you can also do a cranial x-ray and find all of these bones within the sutures. And when you have lots and lots of them, we call them Wormian bones. So this child also had some vertebral fractures. So you have this mild here crushing of the vertebrae. You may look at that and it doesn't really look significant, but the problem is that the spine and the chest are very biomechanical, and so when you start to fracture, others can fracture as well. So this here is a clear indication that this child needs to be treated. 2-year-old boy who has CP, very hypotonic, has epilepsy, has an eating disorder, has a dysphagia, is on tube feeding, nonverbal, and all of a sudden seems to have pain when they're changing his diaper and they're moving his right leg, but there's no history of trauma. So this is likely to be a case of secondary osteoporosis. This kid has lots of factors to have weak bones. He's non-weight bearing. He may be malnourished. He may have a special diet, the anti-epileptic medication that he takes. So this is the typical child with medical complexity. And I've just put a table for you of all the different types of medications that can affect bone and can fragilize bone. So what do you do for these kids when you have a child that you suspect has osteoporosis? Well, you do a typical, calcium, phosphate, magnesium, vitamin D, but you also here, you want to, especially if you don't think it's OI and you want to make sure you're not missing something else, you want to do something a little bit larger. You're looking at the kidney and the liver function. I also do inflammatory markers to make sure that I'm not missing some chronic inflammation. I do a celiac screen as well, because celiac can present with fractures. If the child is very hypotonic without a neurological disorder, or if there's osteopenia on x-ray, I'll even do muscle enzymes to make sure that I'm not missing a neuromuscular disease. And if they're of pubertal age, then you can do the sex hormones. So last case Amy, who's 5 years old, in good health, normal growth. She has a varied diet. She's gone to the park with her mom and dad, and they spent the whole day at the park, and she went sliding on this slide a few times. This is a true case. And then within a couple of days, even that night, started complaining of a little bit of back pain. The day after started getting worse, not responding to Tylenol and Advil. So the parents consult emergency. And at the emergency, what they find is this. So here, this vertebra seems a little bit squashed compared to the others. Retrospectively, maybe this one was a little bit squashed, but this is the one that the doctor sees, doesn't get the radiology report right away. So because the child's in good health, gives a little bit of morphine extra for the pain, and asks for a consult to the orthopedic clinic. Fracture, you think orthopods. So unfortunately, Amy she was better with the morphine, went back to daycare the next day, and unfortunately fell on her bum again. And at that point, the pain became so severe she couldn't walk. So they consult emergency once again, and this has turned into this. So this is a very severe grade 3 fracture. And so now you've diagnosed osteoporosis, right? You have a vertebral fracture in the absence of high energy trauma. You need to figure out what the cause is. And so here, obviously something's going wrong. So there's a blood workup done, and there's a diagnosis of lymphoblastic leukemia with blasts on X-ray. So my point here is, when you have osteoporosis, you have to understand why the osteoporosis is there. If the child is healthy and doing well, and your blood tests are completely normal, then you can go to think about the genetic route. But before you think about genetics, or before you send to orthopedics, you really have to think about, is there an underlying inflammatory or infiltrative disease that is causing these this low bone density and these fractures and this osteoporosis. Last slide, a really quick word on bone pain, because I'm sure you guys get a lot of parents asking you, my child has pain in the legs, especially at night. Is this normal? Is this not normal? Of course, there are growing pains, which tend to happen more in the lower extremities, tend to increase after a day of long activity. Oftentimes not daily, can sometimes wake up at night, but I find that symptom a little bit difficult to look away from. Tends to be just relieved with a little bit of massage, maybe a few Tylenol here and there. Otherwise, the child is healthy and growing well. That's your typical bone pain. But when the child has persistent bone pain or increasing bone pain every single day, waking him up at night, or definitely if it's impacting function, we can't just sit and say, oh, it must be growing pains. There's so many possibilities why that child has pain. I've just listed a few, and obviously they go beyond the scope of tonight, but I would really like you to consider just doing a preliminary workup in that child and some imaging, because sometimes we can see something on imaging. If everything is normal, but the child keeps on having a functional impairment, then I strongly recommend that you refer for MRI, or you refer to a specialist. So I think we've talked about all the reasons when to refer. And so just my wrap up take-home messages: when you have a child and you've confirmed rickets on X-ray, obviously it's most likely to be vitamin D deficiency if the history goes along with that. And if it doesn't, then really you want to look for congenital type of rickets, whether it's hypocalcemic or hypophosphatemic, and make sure that you always follow them up or organize a follow-up 3 months after supplementation. My second take-home message is that bone fragility in pediatrics has to have actual fractures. You can't base that diagnosis just on bone density. My third message is that any child who has vertebral fractures, that's osteoporosis, and you need to figure out what that cause is. And if your child if your patient has lots of bone pain, it could just be growing pains, but there's lots of other pathologies that it could be. So consider a bit of a workup. And my take-home final message is that really your bones are organs, and it's a very dynamic organ, and really bone health definitely contributes to the global health of the child.
Thank you so much, Melissa, for this incredible presentations, because I really it was really on the ball. I discussed with you one of my kids' cases with rickets this week, and I showed my whole clinic with all the residents because it was important for them to know and to see. But definitely, I think we don't, the genetic ones with the osteogenesis imperfect, we don't necessarily see them because they usually, if they have like pathological fractures before, they get referred to specialized care. But it's very important, obviously, like for the leukemia, infiltrative, and all the differential diagnosis that you just mentioned. It's things that we see every day, and definitely in the workup that we have to think about. So I'm going to invite everybody to write questions on the Q&A so I can address them as we go. Dr. De Costa started. So how do you recommend we proceed with a healthy newborn seen in our office with bluish sclera? Do you refer them right away?
That's a really good question. The answer is no, because blue sclera just means that there's a little bit less collagen in the sclera. And actually you see that in osteogenesis imperfecta because there's a lack of collagen, or the collagen is abnormal, but it's also normal up until about 12 to 18 months of age. So unless your child is fracturing, or unless there were prenatal signs that there may have been a bone dysplasia, blue sclera can be completely normal in a child up until about 12 to 18 months of age.
Thank you. Dr. Deal is thanking you for this great talk. Do you see much difference in the assays being used at the children's versus Sainte-Justine for the PTH? Time to results for the 25-OHD and the PTH.
So the question is, are there any differences?
Yeah, in the assays, because apparently there is like a different to have the results.
Well, not only that, Melissa, a couple of years ago, we were talking about getting a very rapid PTH assay at Sainte-Justine. And I just wondered if you would set everyone up to date in terms of where we are with the assays that are being used for PTH at the two hospitals, and whether you see any difference, because PTH is not an easy hormone to get a good dosage for, and it's always been a problem.
Yeah. So what's important to know is that when you do measure PTH, it's, tends to be a specific tube. Most of the time, or at least at Sainte-Justine, it has to be done with the macro method. So actually you have to poke in the vein and not just on the tip of the finger. But now things are changing. There is a new assay at Sainte-Justine where you can, if you ask the biochemist specifically, he'll be able to actually add on a PTH on a biochem micro method. I'm not sure if that's, I'm actually not aware of what's done at the children's, but happy to compare the two. The PTH, maybe a year ago, was the results were taking weeks. Very, very frustrating, but they've actually transitioned to a new machine. And so now we're getting them in about a week and a half, which I think is reasonable. What I recommend is that if it's going to change your management, and if it's really important for you to have that PTH at that moment, then call your biochemist. I've always, I have mine on speed dial, and when I need something really quick, he just takes that patient and puts him into the next batch that's going in to be analyzed. So he bumps them up, and I'm sure that can be done at the children as well. And don't forget that when the PTH also, when it's taken, has to be put on ice. So that's also, there's some technical issues with the way it's handled. And when you order a PTH, most labs, but not all, will automatically give you the calcium and the phosphate, because PTH is meaningless if you don't know what the calcium and what the phosphate are.
As far as I'm concerned, like I got it from the children's, and it was very quick for the case that I mentioned a couple of weeks ago. So I feel the turnover time is not bad at all.
And but what I'm glad to hear you say that, and I agree. I've gotten a fast turnaround, but I haven't been sent the nomogram that Melissa was just talking about that we usually send at Sainte-Justine, where PTH is interpreted by the calcium level, and I haven't seen that done at the children's, and I'm surprised. You know what I mean, Melissa? The lovely diagram that they always give with the PTH results?
Yeah,
exactly. I just wonder why that's not done, because I have patients coming to Tiny Tots that are, comfortable at the children's, so I'll send them there, or comfortable at Sainte-Justine, so I'll send them there. but I need to really understand the differences in the assays. And I'm not sure we really talk a lot about this at ELNA.
So maybe we can, maybe Melissa, you can like speed dial someone that you know from the children's and tell us what's.
I'll send an email and get back to you.
That would be really helpful, I think, for all the docs that have patients that, you know, go on either side of the mountain. Thanks a lot, Melissa.
Well, no problem. What I would recommend though, if you do, for example, if you want to follow that result and you've gone to the children's for your first one, then maybe continue to go to the children's when you do that follow-up 3 months later.
Yeah. Okay. Dr. Cohen is asking, but I'm not so sure, like how to interpret hypophosphatemia versus hypophosphatemia. I don't think there's, I don't.
For me, there's, well, like what we're measuring is phosphate, or sometimes we call it phosphorus, but really what we're measuring is phosphate in the blood. And that tends to be this kind of the same thing. But when we talk about it, we use the terms interchangeably. Does he mean hypophosphatasia, where you have a low alkaline phosphatase?
So I don't know what she meant. Dr. Cohen, maybe you can clarify in the Q&A, because you can even like try to talk.
So I'll just say that, you know, hypophosphatemia is really when your phosphate is low. Hypophosphatasia is when you have a low alkaline phosphatase, that bone turnover marker, but can also be a marker for GI and hepatic function as well. So when that's really, really low, then you have to think of another skeletal dysplasia called hypophosphatasia, where you would have kind of, if it's very severe, you'd have rickets and you'd have poor growth and lots of other different phenotypes as well.
Thank you. So Dr. Morrison is also thanking you for your talk. Can you please review the therapeutic doses of calcium and vitamin D for kids with rickets related to nutritional deficiency?
Yeah, so I can go back. So it's on the slide, but let me get back to it quickly. Basically, it all depends on age. We can go there.
We're going to have also the presentation
yeah, so what I'll do is there's some, I don't have the copyrights to all of the, you know, kind of designs that I have there. So I'll just streamline it and I can send it to you. So basically, we're going anywhere when you're treating nutritional rickets, you want to treat here. We want to do anywhere between 2,005 to 6. I tend to stop at 5,000 units per day, depending on the age. And then, or as a single dose, again, depending on the age. We don't do single doses in children who are less than 3 months old. That's important. Otherwise, the maintenance doses, once you've finished at 3 months, you should go back to maintenance doses. There's no, unless the child has massive cholestasis or, you know, another liver dysfunction that prevents the metabolism of vitamin D. And so you have to compensate with high doses. All children should be on regular doses. So that's about 400 units a day up until 1 year. So these are the same recommendations as, you know, the SCP, the Canadian Pediatric Society. And then at 1 year old, then you can go up to 600 units a day. But if your child's drinking 2 or 3 glasses of milk, you know, maybe all he needs is 400 units. Maybe he doesn't, if he's Caucasian and he's going outside all the time, maybe he doesn't need vitamin D supplementation, but he definitely won't get hypercalcemia or hypocalciuria if you give him that extra 400. You start to get into trouble when it's 1,000 or more daily. So I tend to reserve those doses really for, you know, kids with CP who have absorption issues because of the way they're tube fed or have anti-epileptic, which, so I tend to refer those to very specific populations. And one thing that I didn't mention, but especially when you have those types of populations, and you're giving calcium supplementation, there's always, and they're non-mobile, for example, there's always the risk that you may actually cause hypercalciuria, nephrocalcinosis. So I tend to, when I prescribe higher doses in specialized populations, I kind of tend to do, you know, a calcium level in the blood and urine at least once a year.
Super, thank you. I'm going to ask another question because of the chart that I saw with rickets. if it's not painful, do you doubt the diagnosis? Because you said at the beginning that it is very painful.
No, because children are surprisingly resilient. And so, for example, if you had a kid who's limping, but you're moving the leg and it doesn't seem painful and he's still playing, he's just limping, to me, that's still an antalgic gait. He's still, there's still pain there. They're just really good at tolerating it. And sometimes the pain can be so chronic or so insidious and building up slowly that, the child just gets used to it. So it can be painful, but it doesn't have to be painful for the diagnosis. Really, your diagnosis of rickets is based on your x-ray. You can only diagnose rickets on your x-ray, and then your blood test and your history and physical help you identify what type of rickets it is.
Okay, thank you. And last, maybe like for the autistic children, because we do follow a lot of them.
Yeah.
Is there like a specific supplementation that you choose, for example, for the calcia that you mentioned before, the combinations, because they're usually very selective. So do you go for like the higher doses of vitamin D combined with 500 of calcium, or?
I tend to go I tend to just go with a multivitamin or something that's easy, because you want to get a bit of vitamin C and calcium and vitamin D. So I just oftentimes, and I've spoken to nutritionists about this, you just start them on a multivitamin. The problem is that oftentimes you have to work with the parents to kind of hide that multivitamin in some sort of food, because they're unlikely to just, some of them do. I have one that swallows no problem. And then the risk when you're hiding multivitamins is that then they start to refuse that food, which they've been eating daily for the last 3 months. So then the parents are even more difficult. It's even more difficult for the parents because the diet now becomes more restrictive. So I try and find ways to get the parents to hide a multivitamin, or to try like different types, and to work with their pharmacist to come up with what's the best for them. And I just use, average normal doses. So, 600 units of vitamin D. And I look at what the child's eating. And if the child has 0 calcium in his diet, he's not eating any dairy products. Like, for example, the case I presented, the only calcium was maybe a little bit in whatever preservative was in the ramen, and that vache qui rit cheese once in a while. So he's not getting lots of calcium. So I prescribed him, he was 8 years old. So I prescribed him 1,000 milligrams, which is the recommended daily allowance.
Okay, and then talking about like vitamin D, also supplementation, I have another question about the doses of 1,000 units for teens and healthy kids. Can you comment on that?
I think you have to have a reason for 1,000 units in healthy kids, because you can see that there, do I have to hear? Sorry, I'll get back to it. We said it was 1,300, right? But if your calcium is so much better absorbed through the diet, that even if they don't have a lot of calcium in their diet, but you're giving it to them as a supplement, it's still not going to be absorbed. So ideally the way I try to do it is to get them to find ways for them to increase the calcium in their diet. So if they don't like dairy, and if they're not allergic, they just don't like it, the option I give will try putting it in a smoothie. Or sometimes I'll prescribe the liquid form and they can just add it to something. Or I'll say, eat non-dairy. So example, bok choy, some canned tunas, there's almonds or almond butter, tofu, sardines, and so I give them a list basically of non-dairy foods that contain high calcium, or I send them to, if they have access to a nutritionist, obviously that's even better. But the best way is through the gut first, through the diet first, and then I try to supplement a little bit.
So that was vitamin D.
Sorry, we were talking about vitamin D. D. So vitamin D, if I do give them 1,000 units, it's because their vitamin D level, I've done a vitamin D level before, and it's really low, but not to the point where it's rickets or anything like that. Let's say it's, 35. And it's starting of winter, and I know it's just going to get lower. So I'll give them 1,000 units. But I want to make sure that, that they're taking it well, and they're not, there's no kidney stone history in the family. And then I'd want to decrease that a little bit in the summer to try and get just average levels of vitamin D a day, which is 600.
And is it like okay to tell all our babies like to take it like for the first year, whether they're breastfed or not, just take the supplementation, and then we usually aim for the 600 if they can take it, because that one is not RAMQ covered, and then it's after that they can just like decide to take, even if they have a good diet, to take it every winter, like, and that's what I tell my patients. So I think it's been very variable as what is recommended, really. But since we're not getting to hypervitaminosis, like, and then we have a big range, I think it's for this way.
I think there's different ways of looking at it. You know, the Canadian Pediatric Society just recommends, you know, that kids should have 600 units of vitamin D a day after the age of 1 year, and before that only 400 units if they're breastfed. The global consensus recommendations actually recommend 400 units across the board. So whether you have breast milk or whether you have formula or a bit of both, again, let me remind you, it takes 1 liter of formula to really get that 400 units a day consistently. So that's why when sometimes when I do call at the nursery, I give 400 units to all babies, regardless of what they're taking. It's not, and it's covered, right? So it's not a problem. After 12 months of age, then it depends on the patient, and if they're not drinking any milk at all, and they're not getting any sun exposure, or they have other risk factors, then providing that 600 units, or even if that 600 is not covered and you give that 400 units, it's still better than nothing.
Yeah. Okay, great. I think there was very interesting discussions tonight. Thank you so much for your time. So we'll discuss after like what happens with the presentation, because you said that you might not give it completely, but we'll have some part. I think there's supplementation tables for the calcium, the vitamin D, and then also like the flow chart on what to decide, you know, like for rickets before sending you the patient will be interesting for the group to have. Okay, thank you so much, and have a good night, everybody.
Thanks so much.
Thanks a lot, Melissa. Lovely to see you. Hi to buddies at Sainte-Justine.
Thank you. Thanks, Sherry. Same here. Bye-bye.
Bye-bye.